Speaker will be Dr. S. Vijay Bhaskar Reddy from Pondicherry. He's a well-known person to everyone. He's a senior consultant endocrinologist and managing director of Vijay Diabetic Thyroid and Endocrine Clinic, Puducherry. And he's awarded one of the inspiring endocrinologists of the year 2022 of India. And he's a secretary, Endocrine Society of Tamil Nadu, Puducherry. He's a president, Puducherry Diabetic Research Forum, and is a faculty and Public Health Foundation of India Diabetes and GDM courses. And he has done more than 20 publications in various journals, contributed to the 4 chapters in the textbook. And everyone knows his involvement in organizing the conferences, and his hospitality was reflected in Trend 2024 in Puducherry. And he's a very good speaker too. And over to Dr. Vijay.
Morning, sir. Thank you for the introduction. Thank the organizing team of Receptor for having given the opportunity to discuss this important practical topic today. So I thought easy topic, so it will be easy done, but I realized in the present preparation that easy topic is tough. So I'll go through hypothyroidism, optimizing the treatment. I'm sure all of you will be seeing cases in the day-to-day OPD, whichever practice you are in. So the outline of my talk will be, I'll discuss a few basics of hypothyroidism related to the management. I think part of it Dr. Abhiraman has covered already. And we'll go on straight to the treatment of hypothyroidism, which thyroid hormone preparation, what is the optimal dose, how we reach the optimum thyroxine dose, and despite thyroxine, if TSH is not coming down, despite thyroxine, if symptoms are persisting, and special populations and take-home message. So all these scenarios we'll be seeing in practice. So we are giving thyroxine, TSH is not coming down, we are giving thyroxine, patient is not feeling better. So the basics of hypothyroidism, so it's very simple, that it's low thyroid hormones. We have low T3, T4. So total hormone is the bound and free hormone. Free hormone is the biologically available hormone. So thyroid hormones are produced from your tyrosine. So we have 4-iodine, which is T4, and we have 3-iodine, that is triiodothyronine, T3, and then we have reverse T3, which is inactive. So the important concept which we need to understand for understanding and managing hypothyroidism is to understand the hypothalamo-pituitary axis. So hypothalamo-pituitary thyroid axis. So in endocrinology, mostly we are talking about feedback. So we have the pituitary gland, which produces the thyroid stimulating hormone, stimulates the thyroid, produces the thyroid hormone T3, T4. In relation, T3, T4 is acting and controlling the body's metabolism. It also gives feedback to the pituitary gland. So if you have high T3, T4, it gives feedback to the pituitary and TSH will go down. If you have low T3, T4, the feedback is not there, the TSH will go up. This is the most important thing. So thyroid hormone deficiency, we are going to look at T3, T4, but more importantly at TSH, because Dr. Abhiraman also showed there's a log linear relationship. For mild changes in T4, the TSH is much amplified and shown, and it's very easy to identify. So TSH is going to be the main test which we are going to follow. So serum TSH is the most sensitive index of the thyroid function. We have highly accurate TSH assays, and when you're looking at a thyroid function test, always look at the TSH first. So different labs give different ranges, but mostly we can follow this range, 0.4 to 4.2. It's more than 20 times more sensitive to changes in free T4 or total T4. So it's a barometer of the thyroid function. What we need to understand is it can be affected by age, pregnancy, coexisting illness, and various stress. This graph Abhiraman has already showed. So when the T4 is coming 2 times, TSH is already gone up by 100 times. This is the most important thing. That is why always look at the TSH level. The T4 may be normal in the case, but when the TSH is changing for that patient, that is low. So we also have age-dependent variations in the TSH. This we need to consider. At 80 plus, even 7.5 or 8 TSH can be normal. So hypothyroidism we can classify into primary, where the thyroid is failing, or secondary, which is the pituitary is failing. So most often what you will be seeing is primary hypothyroidism. Secondary or pituitary cause of hypothyroidism, also called central hypothyroidism, is rare, less than 5%. So primary we identify by the feedback mechanism. So when we have low T4, TSH will go up. Subclinical is T4 is normal, only TSH is high. This is the early thyroid failure. Secondary hypothyroidism, you have low T4 and low or normal, inappropriately normal TSH. So this is how, if you have low T4, TSH is not going up, think of central hypothyroidism or secondary hypothyroidism. So most often you will be seeing pituitary cause primary hypothyroidism due to thyroid failure, which is the most common. And if you have normal T4, high TSH, that is subclinical hypothyroidism. Although the definition says subclinical, but actually it's a biochemical definition. You have a normal T4 and a high TSH. Overt hypothyroidism is low T4 and high TSH. When the TSH is not going up despite a low T4, that means there's a problem with the pituitary. So today we are going to discuss mainly about primary hypothyroidism because that's what you will be seeing commonly. So how common is this disease? So place where coming from Puducherry. So survey of maybe 500 women, they found that hypothyroidism is present in around 11.5%. That is around 1 in 10 women the reproductive age have hypothyroidism. So this is quite a huge problem. And most of it is actually subclinical hypothyroidism. So the same scenario, the national scenario also, study of 8 cities in India, overall prevalence of hypothyroidism is around 10%, that is 1 in 10 women. And subclinical hypothyroidism, another 8%. So around 1 in 5 or 1 in 6 in the population can have hypothyroidism. The problem is huge. All of you will be familiar with the low hormones, the hypothyroidism clinical manifestations. So various manifestations are there. We can have fatigue, we can have cold intolerance, we can have weight gain, heavy menstrual periods, infertility. But what is important is these symptoms are non-specific, they overlap with the general population. There is no typical symptom for hypothyroidism. Many people gain weight, everyone has got hair fall. So we cannot always attribute it to hypothyroidism, but we can test for hypothyroidism. If it is problem, we can treat. We should not overrule the test. So you have tested, TSH is normal, you say, but still you are looking hypothyroid and still we are treating that. We should not do. Okay, so overt hypothyroidism, we have to treat everyone. Subclinical hypothyroidism, TSH more than 10 and T4 normal, we treat after confirming again. TSH 5 to 10, we have to individualize it. There are so many reasons why we treat subclinical hypothyroidism, so the list is long. So pregnancy, intention of pregnancy, goiter, therapeutic trial, rising TSH, infertility. So many cases would require treatment even in subclinical hypothyroidism. So coming to the treatment of hypothyroidism, so which thyroid hormone preparation? So I just put the case scenario. This case will follow all through the discussion. 30-year-old lady came with fatigue, weight gain of nearly 10 kilograms, facial puffiness, constipation. TSH showing clearly more than 100 and low T3 and T4. So this is typical primary hypothyroidism. So the treatment of hypothyroidism is whatever hormone is less, we need to replace from outside. We cannot make the failing gland work again. So thyroid hormone replacement is the treatment of choice. So most of the recommendations are from this guidelines for treatment of hypothyroidism given by the American Thyroid Association. This is from 2014. We do not have any major updates since then. So which thyroid hormone preparation we need to use? So all of us will be familiar with levothyroxine sodium or LT4. Now we have T3 also in the market which is available. So we should know for which case we should use T3. We can use a combination of LT4 and levothyroxine and T3. There are some preparations desiccated thyroid. So this we should be knowing what to use. So levothyroxine monotherapy is the preferred choice. This is the standard of care for hypothyroidism. All of you will be using this only. This is why is the preparation of choice for treatment of primary hypothyroidism. Efficacy in resolving the symptoms of hypothyroidism, long-term experience of its benefits, more nearly 100 years, favorable side effect profile, ease of administration because it's oral, good intestinal absorption, long serum half-life, low cost, and we know that T4 is like a pro-hormone. It gets converted to T3 in the tissues of the body. It will provide the T3. That is why the recommendation is to give only levothyroxine monotherapy. We do not need to give T3 or combination straight away. So what are the goals of thyroxine replacement in primary hypothyroidism? So one is we want the patient's symptoms to get relieved, and any biological, physiological markers like pulse rate should improve, then constipation should improve, and then we may look at the lipid profile and see if the lipid parameters are normalizing. And biochemically, what we are going to see is the normalization of the serum TSH. We try to push the TSH to the normal range with some improvement in the thyroid hormones also. But we are looking mainly at the serum TSH level because this is going to amplify and show more. We should also avoid over-treatment, that is iatrogenic thyrotoxicosis, especially in the elderly, because of its adverse effects on the heart and the bones. So, how do we start the dose? So, we see that we are going to start on levothyroxine monotherapy initially. So, in the same case, TSH we found more than 100. So, weight is currently 65 kilograms. So the starting dose of levothyroxine depends on various factors. One is the age, then body weight, etiology of hypothyroidism, degree of TSH elevation, general clinical context, pregnancy status, presence of cardiac disease, serum TSH score. Most of us in clinical practice, hypothyroidism, 100 micrograms. That is the reflects what we have. But there are some considerations extra we need to make. Most often you may be correct with 100 micrograms. But we may have to consider all these factors. So the best approach to levothyroxine initiation, young and middle-aged patients, like this case 30-year-old lady, start off with full replacement dose. That is what will get the TSH to target fast. Start with 1.6 microgram per kg per day. That is 65 kilograms into 1.6, so it will come to around 100 micrograms per day. So start off straight away. There is no role of titrating the dose 25, 50, 75 in young and middle-aged patients without any comorbidities. Subclinical hypothyroidism, TSH less than 10, you can start with 25 to 50 microgram per day. So there is a case for partial replacement. You start low dose and gradually titrate the dose only for elderly and cardiac patients or thyroxine intolerant patients. This is the group where you start 12.5, 25 micrograms and monitor the TSH 4 weekly, 6 weekly and titrate the dose. But generally, you start with full dose 1.6 microgram per kg per day and monitor the TSH level. So, should we use brand name or generic version? Now, a lot of these generic pharmacies have come up. Whatever you write, your patient wants to take generic one. So, they say Modi pharmacy is there, Jan Aushadhi pharmacy is there, I want to take this. So, for thyroxine, this brand name thyroxine is preferably advised. Alternatively, if the patient is insistent of taking generic, we can say that already the thyroxine is cheap, better you take a standard preparation, or they have to maintain the same generic preparation. You should not switch the product. So one time they are taking one brand, another time they are taking another brand. This can cause variation. So make sure I am not for any specific brand. So whatever brand they are taking, they should take, and whichever you are confident that they are manufacturing thyroxine for a long time, better to stick on to that. Don't keep changing to generics. So timing, we need to advise the patients clearly about the timing. So it should be consistently taken 60 minutes before breakfast or any beverages like tea, coffee. The timing actually does not matter. So patients are getting up at 4 a.m., they are keeping alarm, taking thyroxine, quickly going to sleep, getting up at 6 o'clock. So that much effort is not required. So whenever they get up, they can just take the tablet and the time starts after that. They can take half glass of water. I have seen patients drinking 2 liters of water with thyroxine. That is not required. They need to take half glass of water, wait for at least 60 minutes before breakfast, tea, coffee, milk or anything. But most of our patients fasting is after tea only. So we should tell them that tea should come after the tablet. So this is essential for optimal consistent absorption. Any food or beverages will impair the levothyroxine absorption. Sometimes you find that patient refuses to take in the morning. I cannot take, I have to go for work, I cannot get up. In such case, we can give at bedtime, but in the Indian scenario, it is difficult because at least 3 hours after the evening meal, Like places like US, they have this concept of supper where they have dinner by 6 o'clock or 7 o'clock. We are having at 11 o'clock, 12 o'clock dinner and immediately going and lying down. So in Indian scenario, it's challenging. But if your patient is refusing to take in a fasting state, then this is one of the options. After the evening meal, they should take the dinner earlier. So co-administration of other medicines is important. All our patient medicine list is very long. So especially calcium and iron, at least a 4 hour separation is traditional. So even PPIs, antacids, this we should be careful. So duration of levothyroxine, as soon as TSH comes normal, patient is better, can I stop the medicine? So we should usually it's a lifelong treatment. We need to titrate the dose and juggle the TSH in the normal range. Sometimes, rarely you see allergy or intolerance to thyroxine. So we can change the brand. Sometimes there can be allergy to the colorant. So usually 50 microgram, if you notice, most of the brands 50 microgram is white in color. Then we can titrate this white color 50 microgram tablets. Then we can have sometimes intolerance. They'll say allergy, but actually it may be they're not tolerating the thyroxine. They may have anxiety, palpitation, tremor. Then we can pull down the dose. From a full dose, you can start 25 to 4.5, gradually updated the dose. So coming back to our case, so TSH was more than 165 kilograms. So we started straight away on 100 micrograms. So how did we optimize the dose of levothyroxine? So this case started on levothyroxine. After 3 months, she came, TSH come down from 100 to 10. The patient compliance was good. So optimizing the thyroxine dose. So we have 3 stages of thyroxine therapy: initiation, monitoring, and titration. So the goal TSH is to get on the TSH in the normal range. So initially and every time you change a dose, better to do a 3-monthly checkup. Once the thyroxine dose is stabilized, so what is mean by stabilized? 2-3 TSH is coming in the normal range, then you shift the patient to annual checkup or even 2 yearly checkup with all the TSHs coming on. So dose adjustments are done to manage the goal serum TSH. We don't need a T4 or T3 for adjusting this. But if you have a T4, you can have some idea how much to adjust. So this is a study which showed how much the levothyroxine dose has to be adjusted. This is the target TSH level. And 4.5 to 6, they recommend increasing by 12.5 microgram. And from 6 to 7, 25 microgram. 7 to 17, 37.5. And more than 17, 50 microgram. And similarly for TSH, it's going less than 0.01 and 50 micrograms. So like this, some recommendations are there which can be followed for objective dose adjustment. How are we doing with our patients? Similar to diabetes, we always talk about diabetes and finally we say 75% or 80% of the patients are not controlled. Similarly, in thyroid studies have shown that nearly 50% of the patients across various studies, they are not reaching the goal TSH, which is upward. So coming back to our case, so this patient dose was increased from 100 to 125 because the TSH is not fully normal. Called back after 3 months. So the approach summary to hypothyroidism is, so whenever you suspect, measure the TSH and measure the free T4 if TSH is elevated, but most often we do at the same time. Ideally, you need at least 2 measurements unless the TSH is very high. Start a full dose, 1.5 to 1.6 microgram per kg, levothyroxine. Elderly patients, cardiac patients, 12.5 to 25 microgram. Women of childbearing age, we should advise them about the higher dose once pregnant. Repeat TSH after 4 to 12 weeks and then every 6 months when stable. Once the target is reached, we do annual TSH. Target is not reached, we have to consider reasons for treatment failure. So what happens when the TSH is elevated despite thyroxine is not coming down? Suppose this case, so TSH is not coming down, we are chasing the TSH, gone from 100 to 200, still TSH is not at goal. So what do? You're stuck up. So there are so many causes why the TSH remains elevated. Non-compliance is one of the major reasons. So we need to talk properly with the patient and find out. Incorrect medical administration they're taking after tea or breakfast. Inadequate thyroxine dose. Interfering substances. Disorders of malabsorption. I think Dr. Raghuram also showed all these problems, alternative diagnosis like heterophil antibodies, and we can consider a drug absorption test. So what happens, the other scenario, the TSH is normalized, the patient is not feeling better. So TSH, suppose this scenario 100 to 10 TSH, then 1. Patient TSH is normal, we are happy. But patient is not happy. Sir, my tiredness is still not gone, my weight is not reduced, my constipation is not better, what do you do? So if the hypothyroid symptoms are persisting, we have to look at the TSH, and if TSH is high, we adjust it like that case. TSH is not high, that is become normal. Look for other conditions which can cause tiredness or weight gain. Symptoms are resolved. Otherwise, we have to look at other conditions. There are so many alternative causes why people do not feel well. Autoimmune causes, vitamin B12 deficiency, anemia, diabetes, so many other causes, stress. We may not be undermining these symptoms. So many other causes in a patient with normal TSH. After ruling out other conditions like anemia, we have to look at tissue hypothyroidism. So tissue hypothyroidism is low T3 levels at tissue or cellular level. Whatever level of T4 you are maintaining, tissues actually stress. They find out that T3. T3 is most important. Some patients will not be converting the T4 to T3. So tissue hypothyroidism is an important concept. So you have given T4, you have normalized the TSH. Still the patient is not feeling better. You have excluded other conditions which cause the symptoms. Then consider this low T3 levels. So we have T3 also in the Indian market which is available. So the main, you should not give straight away T3 for all the patients. Persistent symptoms despite normalization of TSH with levothyroxine, other conditions like anemia and other causes excluded, think of tissue hypothyroidism, we can consider a trial of T3. When you are going to give this trial of T3, you start 5 microgram twice a day. Consider reducing the thyroxine dose by 25 to 50 microgram when your TSH is normal. So special populations, I think these special populations, we need to adjust the dose, and we cannot give a full dose straight away, or we have to give a higher dose. So children usually require a higher dose, but we need to be aware. Pregnancy, we have to increase the dose. There are pregnancy-specific targets. Elderly patients start low, go slow. They tolerate high TSH levels well. So to conclude, thyroid hormone replacement, levothyroxine monotherapy is the preferred option. T3 selected cases with symptoms despite normal TSH on thyroxine, and you have excluded the other causes. So optimization, start a good dose for young people. Be cautious with elderly or coronary artery disease patients. Monitor the serum TSH 2 to 3 monthly, titrate to goal, and once the goal is achieved, annual TSH, usually it's a lifelong. Thank you.
Though it's a very wide topic, it's trying to cover from A to Z of hyperthyroidism in 20 minutes. Thank you. And then the open for discussion.
Sir? So importance of, we go mainly by serum TSH. So now the TSH, when the TSH is not elevated, then the pituitary causes you will get missed if you are looking at only TSH. So pituitary causes are central hypothyroidism. So you may get missed because they have a normal TSH or low TSH, but that part you will miss it. Another thing is T4 and T3 are more important in thyrotoxicosis rather than this condition. And there are some rare syndromes like thyroid hormone resistance or TSHomas where your TSH will be normal and T3, T4 may be high. So that's mainly pituitary causes you will miss. That's why you need to be a bit cautious. But normally in Indian practice, although they recommend, whether you ask only TSH, they'll always come with 5 reports, T3, T4, T3, T4. So most of our labs are generous. They give you all the values. But practically we are going to look only at TSH. The initial diagnosis stage, you need to be aware what's happening. Another thing which I didn't discuss is thyroid cancer patients where you want to push the TSH levels lower, around 0.1, 0.5 range depending on the risk category. I did not discuss about nutraceuticals. So there are so many tyrosine preparations and vitamins. There is no role for these. You will just give levothyroxine. You find levothyroxine is 1 rupee 50 paise and the nutraceutical, the vitamin tablet is 20 rupees. That much is not required. Yes, madam.
Sir, how long it takes for the weight gain to normalize, sir?
So whatever it is due to thyroxine, the weight gain will reduce by at least 2 to 3 months time. So that's mainly the fluid which is accumulated with hypothyroidism, we are losing that. So practically you are looking at 2 to 3 kilograms or 4 kilograms of weight loss. They are not going to lose 20-30 kilos, although some patients, my patients, they have lost a lot of weight. But practically you have to tell the patient you are giving the thyroxine, but for weight loss they also need to do the extra work, the diet control, exercise. On top of thyroxine, they can at least 2 to 3 months time.
Thank you. I think we will conclude the session with this. The one comment from one side. I have seen patients telling I am taking the medicine for a long time, but it is not getting controlled. But then I told them to bring the L-Troxin bottle. So the problem is that is an expired medicine. Because that she brought for her family, mother also, that is lying down. Now she is diagnosed with thyroid, so she starts taking that. So this also please keep it in mind. Thank you for the wonderful session. Hand over the organizers.
Thank you so much. I just want to add a point here regarding T3 replacement. I have extensive experience. I haven't worked in US. Please do not try to start T3 without the endocrinologist's recommendations. It is not for primary care physician. T3 thyrotoxicosis and atrial fibrillation and toxicity are very frequent and they can happen quickly overnight. So please do not, as primary care physician, if you suspect, please seek endocrine consult. Thank you. And I would like to thank our new endocrinologist on board, Dr. Raghuram, and we welcome to the endocrine family of Madurai. Thank you, sir, for your excellent presentation. And our experienced speaker, Dr. Vijay Reddy. And I would like our chairpersons to felicitate our speakers. Thank you.